Hi, Bacho. I'm Dr. Sakshi Arora Hans, your OBGY faculty at Marrow, and today I am here to give you a recall of NEET-PG 2024 Session 1 and Session 2 OBGY questions. We'll make it short, we'll make it crisp so that you can go through all the questions and the answers very quickly with me. Now, if you ask me about the questions, the type of questions which were asked in NEET-PG, they were very much predictable questions. The topics from where the questions were asked were PYTs. Definitely, the questions were not the same, right? But they were all from PYTs, and there were many questions where you simply had to apply your common sense and you had to just rule out options. Right? So that is why we say MCQ practice is so very important for clearing NEET-PG exams. You know, it is not always that you should have read that topic or you should have known that option, then only you can answer the question. So many times you have to answer question based on ruling out other options, and this particular session, this particular examination was an example of many such questions, right? So let's begin the recall. First question over here was a very, very predictable question. So many times taught to you in class. So many times I have taught to you, not in revision videos. Everywhere I have covered this question, and that is a patient who's a known case of bronchial asthma develops PPH. Which drug should be avoided? I'm sure none of you did it wrong. We all know that the drug which has to be avoided in a patient who has bronchial asthma is carboprost. What are the drugs which are used for management of PPH? Number one, oxytocin. What is the dose of oxytocin which you have to use? 20 international units. And please remember, it should always be given as IM and it should not be given, right? So it should not be given as IV bolus. Why it should not be given as IV bolus? Because it can lead to hypotension and cardiac arrest. And what is the side effect? There is no side effect as such with oxytocin, but oxytocin, whenever you are using in the form of IV infusion, you should always give it in electrolyte rich media. If you give it in electrolyte deficient media like dextrose 5%, it can lead to water intoxication. Right? Then comes methergin. The dose of methergin which has to be used is 0.25 mg IM. And contraindications for methylergometrin, they are after the delivery of first twin. Right, then number one, that is number one, TOPER, that is the normal mnemonic which I teach you in all the classes and in the videos as well. O stands for organic heart disease or any heart disease, right? Organic, we say just because I wanted to make a mnemonic, so I teach you as organic heart disease. Then P stands for peripheral vascular disease, E stands for eclampsia, preeclampsia, PIH, and R stands for RH negative pregnancy. And when you give methergin as IV form, then it can lead to hypertension. So that is a complication or side effect which you have to remember with methergin. Then comes carbetocin. Please remember, carbetocin is a synthetic oxytocin which is used in the management of active management of third stage of labor, but it is not used in management of PPH. Then we have mesoprost, which is PGE1. The dose of mesoprost, which is recommended by WHO, is 800 micrograms, and WHO says that you should give it sublingually or you can give it orally. ACOG recommends the dose for management of PPH as 600 to 1000 micrograms, and one additional route which ACOG recommends, which WHO does not recommend, is per rectal route. Right. Then please remember that misoprostol, it is contraindicated in patients with previous history of cesarean section. It is not contraindicated in asthmatics. And the side effect of misoprost, it leads to dose-related hypothermia and shivering. Then we have carboprost or dinoprost or hembate, which is PGF2 alpha. The dose which you have to give is 250 micrograms IM, and it should be repeated after every 15 to 90 minutes. And maximum dose which you can give is up till 8 doses, that is 2 milligrams. It is contraindicated, number one, in bronchial asthma patients, number two, in pulmonary hypertension patients, and number three, in amniotic fluid embolism patients, and its side effect is diarrhea. So all the drugs related to AMTSL and all the drugs related to PPH you should be knowing. In addition to all these drugs in PPH, you are also using 1 grams of tranexamic acid, right? Then an image was given to you over here of a case of twin pregnancy. 2 cases of twin pregnancy was given, and you had to tell what is the mode of delivery. Now, in one of the image, what you saw was that both the babies were cephalic, and in the second image, first baby was transverse lie. So all of you know that in case of twin pregnancy, when do you have to do a cesarean section? In case of twin pregnancy, cesarean section has to be done if it is a monochorionic monoamniotic twin, or if it is a conjoined twin. At what time do you do a cesarean section? You do a cesarean section between 32 to 34 weeks. Vaginal delivery is possible only in dichorionic diamniotic twins and monochorionic diamniotic twins, depending on the first twin. Which is the first twin? Whichever twin is closer to the internal os, that is called as the first twin. Now, if first twin is breech or transverse lie, then you have to go for cesarean section, and if first twin is cephalic, then vaginal delivery is possible. Now, if first twin is cephalic, then and if, for example, if both the twins are cephalic, you have to deliver both of them vaginally. What you have to remember is, after delivery of first twin, do not give injection methyl ergometrin. If first twin is cephalic and second is breech, first is delivered vaginally, second one is delivered by assisted breech delivery. And if first twin is cephalic and second twin transverse lie, then for the first twin you are going to do vaginal delivery, then you are going to go for internal podalic version, and you are going to convert the transverse lie baby into breech, and that has to be followed by breech extraction. Please remember, internal podalic version, the only indication for internal podalic version is if second twin is transverse lie. It has to be done in OT under general anesthesia, and it is contraindicated in previous cesarean section patients. A very, very important thing which I want you to all to know about delivery of twins is that VBAC is not contraindicated in twin pregnancy. Very, very important. If so, suppose if you have a question which says that there is a case of previous history of cesarean section. So we have a case of previous history of cesarean section. In this pregnancy, she has dichorionic diamniotic twins, and first twin is cephalic. Can you do a VBAC? Definitely you can go for VBAC. VBAC is not contraindicated. Are you understanding, beta? VBAC is not contraindicated in case of twin pregnancy, except if you get a question that first twin is cephalic, second twin is transverse lie, and there is previous history of cesarean section. Now, in this case, beta, I will have to do a cesarean section. Why? Because internal podalic version is contraindicated in previous cesarean section patients, right? So, in this case, yes, I have to do a cesarean section. This is a very, very important case which I want all of you to remember, that if there is previous history of cesarean section, first twin cephalic, second twin transverse lie, you will not say that I will do a VBAC, you will say that I'm going to do a cesarean section. A very funny thing which some of you say is that for the first twin I will do vaginal delivery, for the second twin I will do cesarean section. No, beta, nothing like that. You are going to do a cesarean section, and by cesarean section you are going to deliver both the twins. Now, in this image over here, what you are seeing, that one pair of twins was both cephalic. The one which is both cephalic, I have to go for vaginal delivery. So, vaginal delivery for the first, and in the second pair of twins, what we are seeing in second situation, the first twin is transverse lie. Because first twin is transverse lie, I will have to go for LSCS for the second image, right? Okay, then a 60-year-old female presented with mass per vagina as shown in the image. What is the diagnosis? They had given you an image of prolapse, and you had to identify what kind of prolapse it is. Now, over here, I don't have the exact image, but I want to revise with you all the images related to prolapse. Now, whenever you are getting an image of prolapse, first see whether it is a prolapse of vagina or whether it is a prolapse of the uterus. So, in this case, uterus is at its normal position. What I'm seeing is that there is prolapse of the anterior wall of vagina, right? In this image over here, this was a cystocele which you are seeing, right? In this image, what I'm seeing, it is the anterior wall of vagina. It is the anterior wall of vagina which is prolapsing, but it is the lower part which is prolapsing, so it is a erythrocele. Now, in this image, what you are seeing, in this image, you are seeing that it is the posterior wall of vagina which is prolapsing. So when posterior wall of vagina prolapses, it can be a rectocele, or if lower 1/3 is prolapsing, it can be laxed perineum. In this image, what you are seeing, you are seeing that the pouch of Douglas has prolapsed, and along with it, intestines have prolapsed. That means it's an enterocele. In this image, what I'm seeing, it is the uterus which has prolapsed. So it is a uterine prolapse. And in this image, what we are seeing is that hysterectomy has been done. There is no uterus. Now the wall of vagina has prolapsed. The part of vagina which is left after hysterectomy, the vaginal stump which is left after hysterectomy, when it prolapses, it is called as vault prolapse. So in this case, I can't see any uterus. That means hysterectomy has been done. And now when the vagina is prolapsing, it will not be called as vaginal prolapse. It will be called as vault prolapse. So depending upon what image is being given to you, which wall of vagina is prolapsing, you will have to decide whether it is cystocele, urethrocoele, or whether it is enterocele and rectocele. Right? Okay. Then next question they gave you was a grid over here like this, and they had asked you what is this used to diagnose. So please remember, whenever they are giving you words like anterior wall, perineal body, total vaginal length, posterior wall, even though if we may not have done this grid, still you know that this is for genital organ prolapse. So please remember that uterine prolapse, the earlier classification which we were using for uterine prolapse was Shaw classification, and according to Shaw classification, the reference point at that time was the introitus. The reference point is introitus. Right? So if you see that in first condition, what we are seeing is this is the normal level of the cervix. Now I am seeing that the cervix has come inside the vagina. When cervix comes inside vagina, that is called as first degree prolapse. If it is coming up till the level of introitus, that is second degree prolapse. Third degree prolapse means that cervix and uterus are lying outside the introitus, that is third degree prolapse. There is nothing like fourth degree prolapse. The fourth degree prolapse is nothing that we use the term prosidentia. Prosidentia means it is not only uterine plus cervical prolapse, but also vaginal wall prolapse. So it's the entire uterus, cervix and the wall of vagina which have come out, then that is called as prosidentia. Now these days we are not using the Shaw classification. These days we are using POPQ classification, that is pelvic organ prolapse quantification, where the reference point is hymen, and another classification where reference point is hymen is Baden-Walker classification. What we use is the POPQ classification. According to POPQ classification, as I said, that the reference point is hymen. So over here, the reference point is hymen. So if this over here is hymen. Now, if you see that the prolapse part is lying within 1 centimeter on either side of hymen, if it is lying 1 centimeter on either side of hymen, that is called as second degree prolapse or stage 2 prolapse. So that's a second degree prolapse. If you see that the prolapse part is lying more than 1 centimeters above the hymen, more than 1 centimeters above the hymen, then that is called as first degree prolapse. And if you see that the prolapse part is lying more than 1 centimeter below the hymen, right, then that is called as third degree prolapse, right? And what is prosidentia? Prosidentia is when the entire uterus plus cervix plus the wall of vagina, they are prolapsed. That is called as prosidentia. Now, in case of POPQ classification, there are 9 points which are taken into reference, and then we are seeing that those 9 points, where do they lie in comparison to the hymen, right? How much is the distance between that particular point which we have to see with respect to hymen, and then this grid is used to make a diagnosis of the degree of prolapse. Right? You don't need to know many details. You just need to know that in POPQ classification, it is the hymen is the reference point. What is first degree, second degree, third degree prolapse according to it, and what is prosidentia. And you have to know this is the grid which is used for POPQ classification of prolapse. Right? Okay. Then, next question was a G3P1L1 with previous history of breech delivery underwent an LSCS which was uneventful. Currently, she came with antepartum hemorrhage. She was taken for LSCS during which she lost a lot of blood. Right, so this patient, she is a previous history of cesarean section. During this cesarean section, during this pregnancy, she came as a case of antepartum hemorrhage. She was taken for LSCS where there was a lot of blood loss, and during the cesarean section, hysterectomy was done. See, obstetrical hysterectomy, the reasons for obstetrical hysterectomy are not many. Number one reason for obstetrical hysterectomy is PPH. Number two is placenta accreta spectrum. That means the placenta was not getting separated, and that was leading to intractable PPH, and that is why hysterectomy had to be done. And this is what this image is also showing. In the image, we are seeing that along with the uterus specimen, I am also seeing that the placenta and cord are still attached to the uterus. That means I am looking at placenta accreta spectrum or placenta accreta syndrome. That is what they have written over here. Now, about placenta accreta spectrum, you have to remember that in placenta accreta spectrum, there can be placenta accreta, increta and percreta. Placenta accreta means when the villi are attached superficially to the myometrium. Placenta increta means when the villi invade the myometrium, and placenta percreta means when the villi are attached to serosa. So now they have crossed the entire myometrium and they have reached the level of serosa. The two main pathologies which are seen in placenta accreta spectrum is absent neta layer, right? And number two is a defective decidua basalis. The two most important risk factors for placenta accreta spectrum are if in present pregnancy you are getting placenta previa, right? And that is what you are getting. This patient has come to you with antepartum hemorrhage and there is previous history of LSCS. So previous history of LSCS beta and present pregnancy may if she is having placenta previa. These are two most important risk factors for placenta accreta. The investigation of choice is Doppler ultrasound. A patient of placenta accreta spectrum is going to present to you with intractable PPH and the management in this case becomes hysterectomy. You have to do a cesarean hysterectomy or obstetrical hysterectomy. Now, one very important point which you have to remember is that they are going to confuse you by saying that all of the following are risk factors for placenta accreta spectrum except option A, previous history of cesarean section, option B, previous history of curettage, option C, previous history of myomectomy, option D, previous history of placenta previa. Please remember, previous history of the uterine surgeries can lead to placenta accreta spectrum, for example, myomectomy, for example, excessive curettage, but present pregnancy may there has to be placenta previa. Previous history of placenta previa is not a risk factor. Present pregnancy, placenta previa is a risk factor. What are the signs of placenta accreta spectrum on ultrasound? There will be placental lakes or moth-eaten appearance of the placenta. Now, below the placenta, you get decidua basalis, which appears as a hypoechoic area. Now, in these patients, decidua basalis is absent. So, there is loss of hypoechoic area behind the placenta. And there is disruption of a continuous white line which is seen from bladder up till the uterine serosa. Obviously, if there is placenta percreta, the villi are reaching up till the serosa. So that white line which was extending from bladder to uterus, which was actually the serosa, now it will be interrupted. As I said, management is hysterectomy. Right? Then, this is how placenta accreta, where the villi are attached superficially to the myometrium. This is placenta increta, where the villi are attached, invading the myometrium. And this is placenta percreta, where the villi are attached to the serosa. Next question over here, Ventouse vacuum was applied at the flexion point. What is the correct statement regarding flexion point? Something again which I teach you in all the videos. So what is a flexion point? Flexion point is a point which lies 3 cm anterior to posterior fontanelle. So flexion point will be 3 centimeters anterior to posterior fontanelle, and it is a point which lies 6 centimeters posterior to anterior fontanelle. Please remember, This is where the center of the cup is going to lie. When we are talking about the rim of the cup, it lies at the level of posterior fontanelle. Do you see? It is lying at the level of posterior fontanelle, or the rim of the cup lies at a distance of 3 centimeters from anterior fontanelle. It lies at a distance of 3 centimeters from anterior fontanelle, because the diameter of the cup, which is used in case of vacuum, is 6 centimeters, right? So over here, if you see that the center of the cup is going to lie 6 centimeters posterior to anterior fontanelle, but the rim of the cup is going to lie 3 centimeters posterior to anterior fontanelle, right? So they are saying a vacuum cup is placed at flexion point. What is the correct statement? Midpoint of anterior and posterior, 3 centimeters from anterior fontanelle, 6 centimeters from anterior fontanelle, right? Then cancer cervix lesion staging, growth extended to the pelvic side wall, hydronephrosis is present. What is the stage of the tumor? Now, always in my classes, I'm telling you, ideally, I want you to remember the entire staging of cancer cervix, but in obs and gynae, most of the times, the questions which are asked on stage 3. So, stage 3 is something which you cannot miss, whether it is endometrial cancer, whether it is cancer cervix, whether it is choriocarcinoma, whether it is ovarian cancer. I want all of you to remember stage 3 in all gynae cancers. Now, in which stage is parametrium involved? Parametrium is involved in stage 2B in cancer cervix. Pelvic side wall or hydroureter or hydronephrosis, they are involved in stage 3B. Pelvic lymph nodes are involved in stage 3C1, para-aortic are involved in 3C2, and superficial inguinal lymph nodes are involved in stage 4B. Now, superficial inguinal lymph nodes are involved in stage 4B in case of endometrial cancer, cancer cervix, and ovarian cancer. When we are talking about nodal involvement in cancer cervix is same as cancer endometrium. In both cancer cervix and cancer endometrium, pelvic lymph nodes are involved in stage 3C1 and para-aortic lymph nodes are involved in stage 3C2. Nevertheless, the question which they have asked you, that the growth is extending and there is up till the pelvic side wall and there is hydronephrosis. Hydronephrosis means it has to be stage 3B. Right. Another very important point which I want to quickly revise with you is regarding management of cancer cervix. Please remember that up till stage 2A, the management of choice is surgery. But even up till stage 2A, if the size of the tumor becomes more than equal to 4 centimeters, then you have to go for chemoradiation. Surgery cannot be done. Surgery cannot be done if the size of the tumor becomes more than equal to 4 centimeters, and size of the tumor becomes more than equal to 4 centimeters in stage 1B3 and 2A2. So up till stage 2A, you have to do surgery except for stage 1B3 and 2A2. In stage 1B3 and 2A2, the management of choice is chemoradiation. From stage 2B onwards, management of choice is chemoradiation. If chemoradiation is not given to you in the options, then you are going to say radiotherapy. Why am I saying chemoradiation? Because I am going to use a radiosensitizer drug, which is cisplatin. Cisplatin is a drug which increases the sensitivity of the cells towards radiotherapy. It's not used as chemotherapy, but it is used as a radiosensitizer to increase the sensitivity of the cells. Right? Now the question says that there is a short girl with primary amenorrhea. Whenever your question says primary amenorrhea with short stature, you have to think about Turner's syndrome. And over here, the question was made very easy because they had given you a karyotyping result. Whenever you get a karyotyping result, I want all of you to look at the autosomes, that whether there are 22 pair of autosomes or not. Is there any extra chromosome in the autosome, or is there any chromosome less in the autosome? If there is extra chromosome in the autosome, that will be called as trisomy. So suppose if instead of 2 chromosome number 21, there were 3 chromosome number 21, I would have called it as trisomy 21 because there is one extra chromosome, that is chromosome number 21. Similarly, if suppose there was only one chromosome number 10. I would have called it as monosomy 10. So, right, number one thing, you have to see that. Then you have to look at the sex chromosomes. In this particular patient, I am getting autosomes are all there. So there are 44 pairs of autosomes, plus I am getting only one sex chromosome, and that is X chromosome. So this can be written as 45XO, that is monosomy X, and that is Turner's syndrome. Right, now please remember, in Turner's syndrome you can get something which is called as mosaic Turner's syndrome. What do you mean by a mosaic Turner's syndrome? A mosaic Turner's syndrome means that this particular patient of Turner's syndrome will have two karyotypes. A few cells are going to have 45XO as their karyotypes, and few of them are going to have 46XY as their karyotype. That is why in mosaic Turner's syndrome, on one side you will get streak ovaries as the gonads, and on the other side you will get dysgenetic testes as the gonad. Now dysgenetic testes, they are pre-malignant and they can become malignant, and that is why they require gonadectomy. And this is the reason why in all Turner's patients, whether I am 100% sure that this is Turner's patient, still in all Turner's syndrome patients, you should get karyotyping done. Why you should get karyotyping done? Because we don't know who are mosaics. If they are mosaics, they will have high chances of malignancy. Right, they will have dysgenetic testes, which will have high chances of malignancy. Next very important question which was asked was, there was a female with primary amenorrhea, normal breast development, normal pubic hair development, normal uterus, normal ovary. What is the karyotype? Now please understand, whenever your question is saying that everything is normal, hypothalamic axis is normal, pituitary is normal, ovary is normal. Why am I including this, that hypothalamic and pituitary axis is normal? Because ovary is normal. Ovary will function normally only if hypothalamus and pituitary are functioning normally. Then your question is saying that there is normal breast development, which means estrogen is being produced by this female in sufficient quantities. Normal pubic hair development, which means androgen is being produced in normal quantities. And that means ovaries are functioning properly. And that means everything is normal. Hypothalamus normal, pituitary normal, ovary normal. Other than that, they are saying, now whenever all hormones are normal, you can have two situations. Either it could be a case of Mullerian agenesis. Right? Either it can be a case of Mullerian agenesis, or it can be a case of cryptomenorrhea. Now, your question is saying that there is uterus normal. In Mullerian agenesis, uterus is absent. In cryptomenorrhea, uterus is present. Now, further your question is showing you imperforate hymen. You are seeing that there is no opening in the hymen. And you all know that imperforate hymen or cryptomenorrhea, this is seen in normal females, that is 46XX females. Right? So this over here is a case of cryptomenorrhea. I want all of you to understand that in androgen insensitivity syndrome, the hormonal profile is exactly same like PCOS beta. In case of androgen insensitivity syndrome, LH levels are high, FSH levels are normal, and they have testosterone corresponding to male testosterone levels. And that is why testosterone levels are high. Right, in androgen insensitivity syndrome, the gonads are testes. Plus, another feature of androgen insensitivity syndrome is that they have breast properly developed, but because they are insensitive to androgen, that is why pubic hair and axillary hair are scanty. Right? Another very important thing about androgen and insensitivity syndrome is they do not have any uterus. So again, all these points are going against androgen insensitivity syndrome. So you cannot say it is 46XY. Clear to all of you? Quickly tell me, for breast development, which hormone is required? Estrogen is required. For pubic hair and axillary hair, what is required? Androgens are required. For presence of ovary, what is required? Absence of Y chromosome is required. For proper development of ovary, what is required? Both X chromosomes are needed. What is required for development of male internal genital organs? Testosterone is required because testosterone will promote the growth of Wolffian duct, and Wolffian duct is going to form SEED. Seminal vesicles, epididymis, ejaculatory duct, and vas deferens. For female internal genital organs, what is required? For female internal genital organs, absence of anti-Mullerian hormone is required. When there is absence of anti-Mullerian hormone, Mullerian duct is going to grow, and that is going to form fallopian tube, uterus, cervix, and upper vagina. For female external genital organs, what is required? See, please remember, external genital organs do not depend upon whether the Y chromosome is present or not. External genital organs, their natural tendency is to develop female external genital organ in absence of any hormonal stimulus. So, if there is no hormonal stimulus in intrauterine life, genitalia formed will be female external genitalia. Male external genitalia is formed only if there is sufficient testosterone and dihydrotestosterone in intrauterine life. Clear to all of you? Okay. Then, a P1L1 female with secondary infertility with amenorrhea since 2 years, uneventful previous delivery, laparoscopic image is given. Now, in this laparoscopic image, very, very clearly you could see white areas which were present all throughout the peritoneum, right? On the peritoneum, on the uterus, you could see white colored areas which were nothing but the tubercles of genital TB. So, this particular case is a typical case of genital TB. Important points about genital TB is that genital TB, it is a secondary infection, most common primary infection being the lungs followed by lymph node, and from lungs and lymph node it is going to come into the female genital tract with the help of blood, that is there is hematogenous spread. Although genital TB is a PID, but it is not sexually transmitted, that is why it is the most common PID which can be seen in a virgin female. Most common PID in virgin females is genital TB. The most common site which is affected by genital TB is fallopian tube, and in fallopian tube it is the ampulla which is affected. Now, from the fallopian tube, the infection or the genital TB is going to come into the endometrium. So, if they ask you what is the most common route of spread of genital TB, answer is hematogenous. But if they ask you what is the most common route of spread of endometrial TB, then you have to say it is direct spread. The least common site for genital TB are vagina and vulva. Because it is affecting the tube, the most common symptom which you get is infertility, and because of inflammation, the most common menstrual problem which you get is polymenorrhea. Later on, Asherman syndrome is going to develop in patients of genital TB, and then they are going to have secondary amenorrhea. Most common pelvic finding which you get in genital TB is absolutely normal pelvis. Please don't say frozen pelvis. Pelvis will be absolutely normal. Second most common finding is adnexal tenderness. But if we are talking about an adolescent girl with genital TB, most common finding is adnexal mass. Then what is the investigation of choice? Investigation of choice is endometrial biopsy, which should be done in the premenstrual phase. But please remember, as I told you, genital TB is the most common PID which is seen in a virgin female. In virgin female, I can't do a pervaginal examination. Forget about doing endometrial biopsy. So how am I going to do endometrial biopsy in a virgin female? I am going to take their first day menstrual blood and send it for biopsy. Treatment of genital TB is ATT for 6 months, and treatment for infertility in a patient of genital TB is IVF. These are all the important images which you see on HSG in case of genital TB. Please remember, ideally HSG is contraindicated in patients of genital TB because when the dye is going to come out, it is going to lead to spread of infection. But because in genital TB there is infertility, and whenever a couple come to you with infertility, there are 3 investigations which you have to do. Number 1, semen analysis. Number 2, you have to do a test for ovulation, which generally we do serum progesterone level on day 22 of the cycle. And number 3, a tubal patency test, which we do HSG between day 7 to day 10 of the cycle. Now, because patient is coming to me with infertility, I have to do HSG. But in these patients, HSG is contraindicated. So what I'm going to do is, first I'm going to give them ATT and then I'm going to do an HSG. Right? When you are going to do HSG in genital TB patients, you are going to get certain characteristic appearance. For example, number 1, you can get beaded appearance of the tube. Number 2, you can get lead pipe appearance of the tube, where the tube is appearing absolutely straight. Number 3, you can get golf stick-like appearance of the tube. Number 4, you can get cotton wool-like appearance of the tube. Number 6, you can get tobacco pouch appearance of the tube. Number 7, beta, you can get a bilateral cornual block. Clear? Okay. Next question. A 14-year-old rape victim is 22 weeks pregnant and wants to terminate pregnancy. What is done under MTP Act? Everything related to MTP Act is extremely important, and you know that nowadays pregnancy can be terminated up till 24 weeks, and the only exception is if pregnancy has is a result of contraceptive failure. So in this case, opinion of one doctor is enough? No. Opinion of one doctor is enough up till Opinion of one doctor is enough up till 20 weeks. Between 20 to 24 weeks, 2 doctors' opinion is required. You can terminate pregnancy up till 24 weeks. Yes, termination is allowed between 20 to 24 weeks. If it is detrimental, no, it cannot be terminated, no. Right? So this is what you need to know in case of MTP Amendment Act 2022. Please remember that in case of severe congenital anomalies, you can terminate pregnancy. There is no upper limit. You can terminate pregnancy up till any gestational age. The only thing what is required is it should be approved by medical board. And medical board is formed by a gynecologist, pediatrician and radiologist. Single doctor's opinion is required up till 20 weeks. 2 doctors' opinion is required up till 20 to 24 weeks. What is the qualification to do MTP? Please remember, number 1, if a doctor has MD or DNB or DGO in obs and gynae, then diploma, degree or DNB in obs and gynae, they are qualified to do MTP. Number 2, if it is a registered medical practitioner who has done 6 months of house job in obs and gynae or 12 months of training in any hospital with all facilities. And number 3, any registered medical practitioner who has assisted in 25 MTP cases, amongst which in 5 at least he or she should be the primary surgeon. Please remember, female's consent is needed for MTP, but if the female is a minor, like in this particular case, female was 14 years old, you have to take permission, you have to take consent from legal guardians. Age proof is not required if you can see that the patient is a major. If you are confused whether the patient is a major or minor, you will have to take an age proof. Marriage certificate is not required. MTP can be done in unmarried females. FIR report of the rape is not required, and all records of MTP should be maintained for up till 5 years. So this question was also asked. There is a 27 weeks of gestation. They found a baby with multiple congenital malformation. Parents want to terminate the pregnancy, for which they went to MTP board, which is not a part of MTP board. So is a gynecologist a part? Yes. Is radiologist a part? Yes. Is pediatrician a part? Yes. Is lawyer a part? No. Next question, which was very confusing because many people have given different answers and you people are also wanting a correct answer for this. So this was a female who's pregnant, has come to you for routine scan. She already has 4 girl children. Now she is interested to know the sex of the current child. According to PCPNDT Act, what should you do as a radiologist? Please remember, whenever a radiologist is conducting an ultrasound, they themselves have to fill up a form which says where they declare that neither they are going to look at the sex of the baby and neither are they going to tell the sex of the baby. Right? So please remember, the radiologist has to check for congenital anomalies, but they don't have to look at the sex. So they have to check for congenital anomalies, but not look at the sex. Yes. That is what radiologist has to do. They don't have to look at the sex of the baby. A patient with 32 weeks of gestation had tachycardia and blood pressure 160 by 110. She had pedal edema and proteinuria, 32 weeks of gestation. Pritchard regime with magnesium sulfate was started. What is the indication to stop magnesium sulfate? So everything about magnesium sulfate I've always told you is extremely important. Please remember, magnesium sulfate is an anticonvulsant drug. It is not an antihypertensive drug. It is a centrally acting drug which has got a very low therapeutic range, 4 to 7 milliequivalents of therapeutic range. The Pritchard regime of magnesium sulfate says that you have to give loading dose, which is IM plus IV dose. In IM, you have to give 10 grams of 50% magnesium sulfate solution, 5 grams in each buttock, and you have to give IV 4 gram of 20% magnesium sulfate. Right now, the ampule which is available in your labor room, that is a 2 ml ampule which has got 1 gram of magnesium sulfate. In other words, it's a 50% concentration, and 1 ampule means 1 gram. So if I ask you the total for loading dose, how many ampules of magnesium sulfate should you be picking up? You should be picking up 10 ampules for the IM dose and 4 ampules for the IV dose. That means total 14 ampules you should be picking up. Now, because the magnesium sulfate which is available in labor room is a 50% solution, so when I'm going to give IM dose, simply I'm going to take 5 ampules, give them IM on left buttock, 5 ampules, and give them IM on right buttock. But when I have to give IV dose, I have to make it as a 20% solution because the available in labor room is 50% solution. So what you have to do is, very oftenly asked question, you have to take a 20 ml syringe. And this 20 ml syringe, you will add 4 ampules of magnesium sulfate. But when you are adding 4 ampules of magnesium sulfate, you are adding 4 grams of magnesium sulfate. In other words, 8 ml of magnesium sulfate. Right now, to this 8 ml of magnesium sulfate, you are going to add 12 ml of normal saline. So you have to add 12 ml of normal saline. So now what has happened is, now in this 20 ml solution, there is 4 grams. So obviously, if in 20 ml there is 4 grams, it is a 20% solution. Now don't tell me that how to calculate. So in 20 it is 4, in 100 it is going to be 4 divided by 20 multiplied by 100. And that makes it a 20% solution. Now magnesium sulfate, it has a very, very low therapeutic range, that is 4 to 7 milliequivalents per liter. What does this mean? This means that if magnesium sulfate is less in a patient's body, patient will continue to throw convulsions, and if it becomes more than 7, patient will start showing toxicity. That is why whenever I have to give a repeat dose, which I have to give, the maintenance dose of magnesium sulfate is 5 gram magnesium sulfate IM 50% solution, which you have to give after every 4 hours till 24 hours after vaginal delivery, till 24 hours after delivery, or till 24 hours after the last seizure, right? Whichever event is happening later till 24 hours after that. The later event could be delivery, the later event could be the last seizure, right? Now, whenever I have to give maintenance dose, before giving maintenance dose, I have to check for 3 things. Number 1, deep tendon reflexes. Deep tendon reflexes should be present. Number 2, urine output in 4 hours should have been more than equal to 100 ml. And number 3, respiratory rate should be more than equal to 12. Only if all these 3 criteria are fulfilled, then I give the maintenance dose. Otherwise, we do not give the maintenance dose. Please remember, before giving loading dose, you are not checking the renal function of the patient. Renal function of the patient in terms of urine output is being checked only when you are giving the maintenance dose. So if they say that a patient came to you with renal failure, can you give magnesium sulfate's loading dose? Yes, because I am not even going to check the renal function. So I won't even come to know that they have renal failure. Right? Okay. So they are saying that what is the indication to stop magnesium sulfate? Visual abnormalities, nothing. Respiratory rate more than 18, it's okay. It has to be more than 12. Knee jerk present, it's a very good sign. Urine output 60 ml in 4 hours? No. Urine output should be at least 100 ml in 4 hours. So the answer to this question is option D. A similar question was asked in session 2 as well. Now they are saying there is history of spotting, cervical erosion plus foul smelling discharge. What are the investigations which you would like to do? Now patient has history of cervical erosions, right? What investigation would you like to do? Now, whenever there is a cervical erosion, right, I would like to go for a pap smear. I would like to go for, and there is foul smelling discharge and spotting coming out. That means patient is coming to you with history of bleeding PV and there is foul smelling discharge and cervical erosion. So ideally, I should be doing a pap smear also, and I should be going for colposcopic directed biopsy also. Right? The best answer to this should have been colposcopic directed biopsy. Do I need to do hepatitis B? No. Do I need to do hepatitis C? No. So I have to look for an option where we have pap smear plus biopsy, but I'm not getting any option where there is pap smear plus biopsy. Wherever the term biopsy is given, they have written HCV testing, hepatitis B testing. So all these options are wrong. I am only left with liquid cytology and HPV testing as the option. So I am going to do that. I have to go for pap smear. Instead of pap smear, let's go for liquid cytology. Ideally, I should have gone for a biopsy also, but that's not given. So I'm going for liquid cytology plus HPV testing. This was a question which had to be solved based only on excluding the other options where hepatitis B and C were also mentioned. A P1L1 woman delivered 8 hours before by vaginal delivery. What is the earliest time when you can insert an IUCD? Very, very oftenly asked question. We have done this in marrow notes. We have done this in all the face-to-face classes which I am taking in revision classes. Everywhere we have covered this. So IUCD insertion, it is called as post-placental insertion if you do it within 10 minutes of delivery, and Government of India is recommending post-placental insertion as well as postpartum insertion. Postpartum insertion is if you do it till 48 hours after delivery. Interval is if you do it after 6 weeks of delivery. Now this is very different from laparoscopic tubal ligation. Please remember, whenever we are talking about tubal ligation is called as postpartum from 24 hours after delivery. So we cannot do tubal ligation till 24 hours of delivery. Now from 24 hours after delivery up till 1 week of delivery, if you are doing ligation, that is called as postpartum ligation. And if you are doing ligation after 6 weeks, it is called as interval ligation. Now when you are doing ligation, you have two methods. One is laparoscopic tubal ligation. Another one is mini laparotomy. Please remember, laparoscopic ligation is contraindicated in postpartum period. Mini laparotomy can be done in postpartum period. Right? So if they ask you what is the most common method for postpartum tubal ligation, most common method of tubal ligation, if they ask you simply this question, it has to be laparoscopic tubal ligation. But if they ask you most common method of postpartum tubal ligation, then it has to be mini laparotomy. Why can't you do tubal ligation in the postpartum period? Because all of you know that immediately after delivery, the height of the uterus is just below the umbilicus. So I don't have any space to put laparoscope. The moment I will put laparoscope, it is going to result in uterine perforation. So the question here, it was asked that what is the earliest time to insert IUCD? Earliest time is within 10 minutes of delivery, which is called as post-placental, or you can go for postpartum, that is within 48 hours of delivery. Right. Next question is identify the image. Nothing was given except an image which was taken as a spotter. Very, very, significant or very, very characteristic image of a chocolate cyst. So this over here is chocolate cyst of ovary, which is also called as endometrioma. Please remember, endometrioma can be managed only surgically. They cannot be managed medically. If your patient is desirous of pregnancy, then do not manage it surgically till she has completed her family. Once you get a patient who doesn't desire pregnancy, and if it is a asymptomatic cyst or the size of the cyst is less than 5 centimeters, you don't have to do anything. If it is asymptomatic but the size is more than 5 centimeters, or it is symptomatic cyst of any size, then it has to be removed by laparoscopic cystectomy. Clear to all of you? Then a lady with 37 weeks of gestation comes to OPD for antenatal checkup. She's on warfarin for prosthetic valves. What would be the management of this patient? So I have told you this in class that anticoagulants in pregnancy whenever there is a patient with prosthetic valves, if the prosthetic valve was a bioprosthetic valve, then in pregnancy you have to give only aspirin. And if it is a mechanical valve, then you have to give aspirin plus you have to give anticoagulant. Which anticoagulant you have to give? That depends on the period of gestation. This depends on period of gestation. Another thing which I want you to note is if the patient is giving you history of DVT, there is no valve replacement, but your question says that patient has history of DVT. In patients with history of DVT in pregnancy, you have to give them low molecular weight heparin. You don't have to say that I will see the period of gestation and then I will decide the anticoagulant. Now, as far as your prosthetic valves are concerned, I told you that up till 12 weeks, the anticoagulant of choice is either warfarin if the dose of warfarin is less than 5 milligrams, or you will otherwise have to change to low molecular weight heparin. If dose of warfarin which she was using before pregnancy is more than equal to 5 milligrams, then you will have to shift to low molecular weight heparin. Right, then at 12 weeks, right, and up till 36 weeks, all patients have to be kept on warfarin, right? Irrespective of the dose, now you have to give them warfarin. Right, then at 36 weeks, you switch from warfarin, you switch to heparin. Why do you switch from warfarin to heparin? Because of two reasons. Number one, warfarin is a very, very strong anticoagulant. Now, if my patient goes into labor with warfarin, there are high chances of PPH. Number two, warfarin can cross the placenta. So obviously, if it can cross the placenta, after 36 weeks, if it is crossing the placenta, it will going to reach the babies, and in baby, it is going to create a state of anticoagulation. So when the baby is going to pass through the narrow birth canal, right, there are high chances of intracranial hemorrhage during vaginal delivery. That is why at 36 weeks, I have to change from warfarin to heparin. Then on the day of delivery, you should stop low molecular weight heparin. Which heparin were you changing into? You were changing into low molecular weight heparin. Now, 6 hours after vaginal delivery and 12 hours after cesarean section, you restart anticoagulation. Now, the anticoagulation with which you restart is unfractionated heparin plus warfarin. Why unfractionated heparin? Because it has very, very easy and quick reversal. And once the INR becomes 2.5 to 3, you have to withdraw unfractionated heparin and you have to then continue with warfarin. Please remember, at 36 weeks, you also stop aspirin, right? And you are going to resume aspirin 6 hours after vaginal delivery or 12 hours after cesarean section. So this is how you have to give anticoagulants in case of valve replacement. So the question which they had asked was that a patient has come to you at 37 weeks and she is on warfarin for prosthetic valve. What will you do? Are you going to continue warfarin? Are you going to do immediately cesarean section? No, I'm going to change her to low molecular weight heparin. Please remember, if a patient is on warfarin and she goes into labor, then you will have to go for a cesarean section so that you can prevent intracranial hemorrhage, which happens in the baby during vaginal delivery. So if a patient is on warfarin at the time of labor or within 2 weeks of delivery, then you have to go for cesarean section. Remember this line. If the patient is on warfarin at the time of labor or within 2 weeks of delivery, then you have to go for cesarean section. So next question is what I was talking to you about, and the question is saying that there is a woman at 30 weeks of gestation who has calf pain and redness of the calf. A diagnosis of DVT is made. What are you going to use in management? So for management of DVT in pregnancy, you have to use only low molecular weight heparin, that is enoxaparin. Right? A pregnant woman with history suggestive of hyperthyroidism with 8 weeks POG, what is the drug of choice? So drug of choice for hyperthyroidism in pregnancy is propylthiouracil, especially in first trimester. In second and third trimester, you can use methimazole or carbimazole. Important points which you have to know is fetal gland starts producing thyroxine from 12 weeks. That is why in first trimester, fetus is dependent on maternal thyroxine. So if a patient of hypothyroidism is going to conceive, you have to increase the dose of thyroxine by 30 to 50%. Maternal T3, T4 can cross the placenta. That is why it is fulfilling the requirement of the fetus. Maternal TSH cannot cross the placenta. Right? What is the most common cause of hypothyroidism in pregnancy? It is Hashimoto's thyroiditis. What is the most common cause of hyperthyroidism in pregnancy? It is Graves' disease. What is the drug of choice for hyperthyroidism in pregnancy? Propylthiouracil. In first trimester, it is propylthiouracil. In second and third trimester, it is methimazole or it is carbimazole. Why is methimazole and carbimazole contraindicated in first trimester? This is because it leads to this kind of a condition which is called as aplasia cutis. Right? Please remember, for management of hyperthyroidism during pregnancy, radioactive iodine is absolutely contraindicated. And if they ask you what is the drug of choice for thyroid storm in pregnancy, please do not say propranolol. The drug of choice is propylthiouracil. For symptomatic relief, yes, you are going to give propranolol. Clear? So these were the questions which were asked in session 1. Now coming to all questions which were asked in OBGY in session 2. So there was this image which was given over here, and they said how much time does the embryo take to reach from point A to point H, that is from fallopian tube, it is going to the site for implantation. That means, in other words, they are asking you when does implantation occur. Please bacho remember that initially when a zygote is formed, fertilization is going to happen in the ampulla of the fallopian tube, and fertilization occurs on day 14 of the cycle. A zygote will be formed, and after 20 to 30 hours, it starts dividing to form a 2-cell zygote, 4-cell zygote, 8-cell zygote. 8-cell zygote is called as a morula, and it is also surrounded by zona pellucida. Then it forms a 16-cell zygote. 8-cell and 16-cell zygote, both of them are called as morula. Now this 16-cell morula is going to enter on day 4. It is going to enter the uterine cavity. So remember one very important thing. Morula enters the uterine cavity. That is one thing which you have to remember. In which state? In a 16-cell state, it is going to enter the uterine cavity. Right? Now suppose they say that morula enters the uterine cavity, option A between day 3 to day 4, option B 4 to 5 days, option C 5 to 6 days, option C 2 to 3 days. Most of you, I know, are going to answer it as day 4 to day 5. That is wrong answer. You have to answer it as between day 3 to day 4. Now after that, on day 5, the zona pellucida is lost, and now the morula becomes converted into a blastocyst, and on day 6 implantation begins. Right? When I say day 6 implantation begins, it is 6 days after fertilization. 6 days after fertilization means if on day 14 fertilization had happened, then 6 days after this means day 20 of the cycle. Right? Now, what is the site for implantation? The site for implantation is the upper posterior wall of the uterus. What is implantation window? Implantation window is the time when the uterus is most receptive to this blastocyst, which is 6 to 10 days after fertilization, or you can call it day 20 to day 24 of the cycle. When does implantation end? Implantation ends on day 11 of these. It ends 11 days after, 10 to 11 days after fertilization. Right? Now, some females have bleeding at the time of implantation. If there is bleeding at the time of implantation, what is this called as? That is called as Hartmann sign. Right, now your question was that how much time does it take from A to reach H, that is how much time it is taking for implantation. They are asking over here. Option A is 5 days, B is 8 days, C is 14 days, D is 2 days. 5 days, 2 days, 14 days is a wrong answer. Implantation happens between day 6 to day 11 of the cycle, and over here between day 6 to day 11 we have 8. So I'm going to mark the answer as 8. Now, next question. A 30-year-old P2L2 presents with mass per vagina. She has infravaginal elongation of the cervix. How will you treat her? So, she is a reproductive age female, and she has infravaginal elongation of the cervix, and they are asking how you are going to treat her. This means that she has prolapse, right? And she's a reproductive age female, and she doesn't require any future childbearing. Now, please remember, there are certain named surgeries which I want all of you to remember, and I want you to remember which surgery is done for prolapse in which age group. Now, when it comes to prolapse, it can be a vaginal prolapse or it can be a uterine prolapse. When we are talking about vaginal prolapse, please remember, surgery for vaginal prolapse is constant in all age groups, and it is constant irrespective of the patient's family is complete or not. So, surgery for cystocele and erythrocele is always called as anterior colporrhaphy. Right, no matter what is the age, whenever there is cystocele or erythrocele, I will do anterior colporrhaphy irrespective of whether patient's family is complete or not. So, surgery for enterocele is mechalcaldoplasty. The outdated surgeries for enterocele, they are Moskowitz repair, right, and Halban repair, right. Then surgery for rectocele is posterior colpoperineorrhaphy. Then, if prolapse happens in reproductive age female, and this prolapse is now a uterocervical prolapse they are talking about. If uterocervical prolapse happens in reproductive age female who wants for future childbearing, number one thing, please remember, uterine prolapse should be treated surgically when it is a third degree prolapse, right? So, prolapse in a reproductive age female who wants future childbearing, what am I going to do? I am going to perform sling surgeries, and these sling surgeries are called as cervicopexy. If prolapse happens in reproductive age and they do not want future childbearing, that is called as Fothergill's repair, or it is called as Manchester repair. Fothergill's repair or Manchester repair is specially done if there is elongation of the cervix. So over here, the patient is 30 years old, she is reproductive age, she has 2 living children, and there is elongation of cervix. So I have to do Fothergill surgery or I have to go for Manchester repair. Both are one and the same thing. In Fothergill surgery, there are 2 important steps. Number 1 step is you go for amputation of the cervix. And number 2 is plication of cardinal ligaments. Now, if they say that prolapse is happening in a menopausal female, which is the most common age group for prolapse, you are going to go for vaginal hysterectomy. If your question says that there is a third degree prolapse which is happening and the patient has, along with prolapse, she has cystocele and rectocele, that means I will have to do vaginal hysterectomy, plus I will have to do anterior colporrhaphy, plus I will have to do posterior colpoperineorrhaphy. Together, this is called as Ward-Mayo's hysterectomy. Right? Now, if prolapse happens in a menopausal female who has some contraindication to surgery, then what you go for is Lefort's colpoclysis. Now, if prolapse is happening in a female who's more than 65 years and there are other comorbid conditions, you are going to put a ring pessary. Ring pessary should also be put if there is prolapse happening in a pregnant female or prolapse happening in a female who has just given birth to a child. Management of wall prolapse. So, management of wall prolapse can be done vaginally, and the vaginal surgery which you have to do is uterosacral suspension. Right? Then please remember, but this is the most commonly done surgery, but it is not the best surgery. The abdominal surgery and the best surgery for this is sacral colpopexy. We will talk about sacral colpopexy just now. Now, what is SUI? SUI is involuntary passage of urine whenever intra-abdominal pressure is increased. For example, while coughing, while laughing, while sneezing. What is the surgery for SUI? The best surgery or the gold standard surgery is Bursch colpo suspension. Right, but the most commonly performed surgery is TOT, which is tension-free transobturator tape, followed by TVT, which is tension-free transvaginal tape. For uterine inversion, the surgery which are done are Haultain surgery and Huntington surgeries. So these are the names of the surgeries which you have to remember. For VVF, the surgery which you do is Chaser-Moyer technique or Latzko technique. Latzko technique. Latzko. Latzko. Right? So these are the surgeries which are done for vesicovaginal fistula. Now they are saying what is the most common site for tubal ligation and the reason for ligation at this site. Now, most common site for tubal ligation is isthmus. Ampulla is not the most common site. The options which they have given are isthmus is the narrowest part. No, please, beta. Intramural part or interstitium is the narrowest part. Isthmus has uniform muscle thickness. That is why it is chosen as a site for tubal ligation. So that by chance, if you have to do an anastomosis, right, in that case, when you are going to, join the two parts of the tube, then there will be equal thickness of the muscle which you will be joining, and so anastomosis is going to give good results. And that is why best anastomosis is seen if there is isthmo-isthmic anastomosis in case of reversal of tubal ligation. But for all practical purposes, remember, tubal ligation is a permanent method of contraception. Rarely you may need to go for reversal, and then isthmo-isthmic anastomosis has the best prognosis for reversal. Right? Then, a lady presents with chronic abdominal pain which increases during menstruation. Ultrasound reveals an adnexal mass with homogeneous echoes. Please remember, whenever your question says that there is an adnexal mass with homogeneous echoes, that is how a chocolate cyst presents to you. A chocolate cyst, a typical description is that it is a cyst with homogeneous internal echoes. Every time in my recordings, in my face-to-face classes, I'm always stressing on this point. Or this is also called as ground glass appearance. Right? Normally a cyst should appear jet black in color, but in case of chocolate cyst, the fluid is so thick that it does not appear jet black in color. It gives you a ground glass appearance, or there is homogeneous internal echoes. Right? MRI shows T1 hyperintense mass with no fat separation. T2 showed low signal with dark shading. Identify the disease. So patient coming to you, number one, with pain. That pain increasing during menstruation. Right? And adnexal mass with homogeneous internal echoes leaves no doubt that we are dealing with chocolate cyst of the ovary, and the chocolate cyst of the ovary is also called as endometrioma. Next important question. A lady underwent a mediolateral episiotomy during normal delivery. Wound was sutured. After 6 months, she presented with pain at episiotomy site, which increased during her periods. Please remember, any pain which is increasing during periods directly points out that the reason for that pain is hormonal, and the hormonal disease which you have to know is endometriosis. This means your patient is having scar endometriosis. Remember, scar endometriosis can be seen in episiotomy scar, it can be seen in hysterotomy scar, it can be seen in a classical cesarean section scar, myomectomy scar. Everywhere you can get a scar endometriosis. Scar endometriosis is least likely in a hysterectomy scar. This over here is hysterotomy, it is not hysterectomy. Right? So whenever your question is saying that the pain is increasing at the time of menstruation, always and always think about endometriosis. Next question over here. A lady presented with lower abdominal pain. On day 2, TVS was done. A left adnexal cystic mass was seen with cogwheel appearance, incomplete septa. Very, very important thing. Patient coming to you with lower abdomen pain, on ultrasound, you are getting cogwheel appearance. This is typically what I tell you in case of PID. In case of PID, when you are doing ultrasound, there are 3 important signs which you can get. Number 1, you can get a beads on string appearance. Do you see over here? This is the fallopian tube, and in the fallopian tube, do you see that there is a bead of string appearance? Number 1. Number 2, you can get thickened tube, and along with that thick tube you can get cogwheel appearance, right? And number 3, you can get waist sign. How do you draw the waist of a young girl? This is how you draw it, right? And this is how the tubes can also appear. This is what is called as waist sign. So there are 3 signs which you can get on ultrasound in case of PID. Please remember, a patient of PID comes to you with a lower abdominal pain, and plus they can be any one of the following. And what is that any one of the following? That any one of the following can be uterine tenderness, it can be cervical movement tenderness, or it can be adnexal tenderness. NACO says this is what is called as the minimum criteria for PID according to CDC. And NACO says based on these findings only, you have to give your NACO's syndromic management kit for PID, and the number of kit is kit number 6, and it is a yellow colored kit. Right? NACO says you don't need to do any investigation. Based on minimum investigation and history and examination findings, you have to treat. Now, CDC says that if you have to do investigation in case of PID, other than routine investigations which you will do for ESR, WBC count, you have to go for 3 investigations: endometrial biopsy, ultrasound, and laparoscopy. On endometrial biopsy, in case of PID, you will get endometritis. On ultrasound, in case of PID, you can get any of these 3 signs: cogwheel sign, waist sign, right, or beads on string appearance. I want all of you to be very, very careful. If your question is saying on ultrasound you are getting beads of string appearance, that means it is a case of PID. If on HSG you are getting a beaded appearance of the tube, on HSG, if you are getting a beaded appearance of the tube, that means it is a case of genital TB. If there is a necklace pattern which you are getting on ultrasound in ovaries, then that is PCOS. Clear to all of you? Now, laparoscopy mein, you are going to see that pus is coming out from the fimbrial end of the tube. Laparoscopy is considered as gold standard investigation for PID. Why? Because you can take a specimen for culture and sensitivity. Then you can go for staging of PID. Please remember, the staging of PID is given by Ganswell. So it is Ganswell staging of PID. Then along with this, you can see that whether these females can conceive in future and what are the chances of conception by a Bohr-Meisel score. This Bohr-Meisel score is a score for conception in patients of PID. It tells you whether what are the chances of conception by a patient of PID. So that is why laparoscopy is considered as gold standard, right? Next very important question is, during LSCS of a patient who presented with breach, the following finding is noted: an image of 2 uterus was given. On per vaginal examination, 2 cervix are felt. Every time I have told you in Mullerian malformations that whenever you are getting 2 cervix, it means you are looking at didelphys uterus. In a didelphys uterus, vagina may be single, vagina may be double. But always and always you are going to get 2 cervix, and because you are getting 2 cervix, you will always require 2 Leach-Wilkinson cannulas. Imagine a single vagina and 2 openings of cervix, 2 external os. So if there are 2 external losses, in other words 2 cervix, I will require 2 Leach-Wilkinson cannulas, even though there may be a single vagina. So always in a diadelphic uterus on HSG, you are going to get 2 Leach-Wilkinson cannulas. Whenever your question is about Mullerian malformation and it says there is a single fallopian tube, it means they are talking about unicornuate uterus. In a unicornuate uterus, there is single Mullerian duct, and that single Mullerian duct is going to lead to single fallopian tube. Now, whenever your question says that there are 2 uterine horns, single cervix, single vagina, it can either be biconnuate uterus or septate uterus. If the fundus of the uterus is divided, right? So, if the fundus of the uterus is divided. So, over here, these are 2 fallopian tubes, 2 uterus, single cervix, single vagina. If the fundus is divided, you call it as bicornuate uterus. So you have to look at the fundus of the uterus. Whereas in case of septate uterus, I am going to get a septa. Right, so yes, again there will be two fallopian tube, there will be two horns of the uterus, single cervix, single vagina. But the difference is over here the fundus is not divided. If fundus is not divided, then that is a septate uterus. Next, if they say that there is a flat topped uterus, uterus is flat, the fundus of the uterus has not become dome shaped, then this is called as arcuate uterus. So over here, please remember, the moment the question said that there are two cervix, it means it is a uterus didelphus. Clear to all of you? Next question. A lady undergoing treatment for infertility was found to have bilateral tubal block on HSG. What is the most appropriate next step? So whenever you are getting a question on tubal blockage, please remember, for tubal patency, the investigation of choice is HSG. But the gold standard investigation is laparoscopic chromopertubation. And whenever I am getting a block on HSG, my next step has to be laparoscopic chromopertubation. Right? Now, this rule is going to apply whether I am getting a cornual block or I am getting a distal block. Whether the block is cornual or whether the block is distal. Now, this image over here is showing you Leach-Wilkinson cannula. This is the cannula with which you pass the dye. What is the name of the dye which you pass in case of HSG? It is urographin. Please remember, urographin is a water-soluble iodinated dye. Right? And when do you perform HSG? You perform HSG between day 7 to day 10 of the cycle. Now, over here you are seeing that the dye has gone inside the uterus. It has gone up till the angles of the tube, but it has not gone any further. So, this over here is an HSG showing you a bilateral cornual block. Now, if they ask you what is the most common cause of this kind of HSG or bilateral cornual block, HSG is a painful procedure. So, when you pass the dye, it leads to cornual spasm and that leads to bilateral cornual block. So, the most common cause is physiological. Right? So, whenever you are getting bilateral cornual block and they ask you next step, please remember, I have to do laparoscopic chromopertubation. But in case of bilateral cornual block, I will also go for hysteroscopic cannulation. What do you mean by this? Under the guidance of hysteroscope, I will take a thin wire and I will pass it from the cornual end of the tube. If the tube has gone into spasm, the spasm will get relieved, and then I will pass a dye and see from the laparoscope whether the dye is coming out or not. So remember, in case of blockage of HSG, whenever you get a block on HSG, you have to do laparoscopic chromopertubation. In case of cornual block, along with laparoscopic chromopertubation, you have to do hysteroscopic cannulation. Hysteroscopic cannulation. So sometimes in your options, they don't give you this entire thing, laparoscopic chromopertubation plus hysteroscopic cannulation. They will simply say laparoscopy plus hysteroscopy. Clear to all of you? So over here they are saying that you are getting bilateral tubal block on HSG. What is the most appropriate next step? Most appropriate next step is laparoscopy with chromopertubation. Most of the times when you are going to do this, the block is going to get relieved. Most of the times the block is relieved. If by doing this, the block is not relieved, that means it is pathological block, and the most common pathological cause of bilateral cornual block is genital TB. And in this case, the management becomes IVF. Clear to all of you? Next question. A 45-year-old lady presented with menorrhagia. Okay, hysterectomy was done and following was seen. What you are seeing over here? Over here you are seeing that there is a mass which has arisen from the uterus and the contour is rough. It has a rough contour, right? Then it is arising from a broad base, right? Not only this, what you are seeing other than this, you are also seeing that it is white in color, right? And it is well circumscribed. That means probably it is surrounded by a pseudocapsule. This is how a fibroid looks like. So this is an intramural fibroid. Please see, this is what I show you in the classes and in the marrow videos also, that this is a typical appearance of a fibroid, where it is showing you whorled appearance, where it is showing you that it is arising from a broad base, it is white in color, and it is surrounded by a pseudocapsule. All the blood vessels which supply the fibroid, they are present in this pseudocapsule. Remember that. And that is why the most vascular part of the fibroid is the pseudocapsule or the periphery of the fibroid. And the least vascular part is center of the fibroid. When it comes to a polyp is red and fleshy, right? And it arises from a narrow base. It is a mucosal growth, right? And whenever we are talking about a polyp, please remember a polyp is supplied by a single blood vessel which goes up till its center, and that forms the basis of the feeder vessel sign which you get on Doppler, right? Then over here, this is a specimen of adenomyosis. Whenever there is adenomyosis, what is adenomyosis? Adenomyosis is when endometrium is present inside the myometrium. Whenever endometrium is present inside myometrium, there will be myometrial hypertrophy, and that is why the uterus will be uniformly enlarged and it will be globular. The enlargement of the uterus is never more than 12 weeks pregnant uterus size. Very, very important difference between fibroid and adenomyosis. In fibroid, the uterus may reach up to 20 weeks pregnant uterus size, not in adenomyosis. In case of fibroid, because fibroid is arising from one side, there will be asymmetrical enlargement of the uterus, whereas in case of adenomyosis, there is going to be symmetrical enlargement of the uterus. Then in case of adenomyosis, uterine tenderness is present. And this is what is called as Halban sign. This is not seen in case of fibroid. When you are going to see a cut section of adenomyosis, you are going to see multiple hemorrhages. Why are they multiple hemorrhages? Because the endometrium which is present inside the myometrium is hormonally active, and every month it is going to bleed. So these are all the images which you have to remember from fibroid, polyp and adenomyosis. Next, which of the following is not a contraindication to the procedure shown in the image? So in the image, what procedure was shown was external cephalic version. Please remember, external cephalic version, it should always be done at more than equal to 36 weeks of pregnancy. Ideal time to do it is 37 weeks. Liquor should be adequate and membranes should not be ruptured. So if I say that what is an absolute contraindication, oligohydramnios and ruptured membranes are absolute contraindication. Another prerequisite is it can be done in latent phase of labor or early labor. So an absolute contraindication is active phase of labor. Then external cephalic version can only be done in singleton pregnancy. So absolute contraindication is twin pregnancy or multifetal pregnancy. Please do not confuse external cephalic version with internal podalic version. Internal podalic version is done in twin pregnancy when second twin is transverse lie. External cephalic version can be done only in singleton pregnancy. Then fetal heart rate should be monitored on CTG. That is a prerequisite. So abnormal fetal heart rate on CTG is an absolute contraindication. There should be no contraindication for vaginal delivery. That's an absolute prerequisite. In other words, if your patient has placenta previa or contracted pelvis or uterus or fetus are grossly deformed, you cannot go for external cephalic version. These are absolute contraindications. Relative contraindications are PIH, heart disease in the mother, IUGR and previous history of LSCS. Right? Now your question was, which of the following is not a contraindication? Twin pregnancy is a contraindication. Placenta previa is a contraindication. Premature rupture of membranes is a contraindication. Primi gravida is not a contraindication for external cephalic version. Next question is, a forceps is used for delivery of after coming head of breech. Identify the forceps. There is only one forceps which is used for delivering the after coming head of breech, and that is Piper's forceps. Now in forceps, there are three images or three types of forceps which you may be required to identify. One of them is a short forceps or an outlet forceps, and two of them are long forceps. First of all, understand that when these images are given individually to you, how do you come to know whether it's short or long? In order to know whether it is short or long, you should compare the length of the blade with the length of shaft and handle. If length of blade and length of shaft and handle are almost equal, it means it is a short forceps, and there is only one short forceps which you need to know, which is an outlet forceps called as Wrigley's forceps, right? Now, if you are seeing that the blade is shorter and the shaft and the handle are much longer, that means you are looking at long forceps. Now, normally in all forceps, you get an English lock. Locks which are like these are called as English locks. There is only one forceps which has got a button-shaped lock like this. And this button-shaped lock is called as sliding lock. So if you are getting a long forceps with sliding lock, long forceps with a sliding lock, that means you are looking at image of keeled forceps. Please remember, keeled forceps is outdated these days, and it is the only forceps which could rotate the head of the fetus. But it is not used these days. It is the only forceps which could rotate the head of the fetus. Between forceps and vacuum, this is the difference. Forceps cannot rotate the head of the baby, whereas vacuum can rotate the head of the baby. The only forceps which could rotate the head of the baby was keeled forceps. Number two, if you are getting a long forceps and you are getting English lock, then it has to be only one forceps. It is Piper's forceps. Piper's forceps is used for delivery of after coming head of breech. Right, so it is used for delivery of after coming head of breech. Now please remember, normally in all forceps there are two curves which you get. The outer curve is called as the pelvic curve, and the inside curve is called as cephalic curve. Now, Piper's forceps is the only forceps where you are getting an additional curve which is called as perineal curve. This is the only and only forceps. So even if you are unable to identify perineal curve, if you are seeing it's a long forceps and it has got English lock, that means you are looking at Piper's forceps, right? Next question is, during delivery, the maneuver is shown in the image is done. As the hairline on the neck is visible, identify the maneuver. So what are you doing? So first of all, you are seeing that this is a case of breech. Then you are seeing that the head of the baby is getting delivered and we are lifting the feet of the baby towards mother's abdomen. That means it is Byrne-Marshall maneuver. Now, before you mark the answer as Byrne-Marshall maneuver, a word of caution. Always and always look at where the back of the baby is. If back of the baby is anterior, then it means it can be Byrne-Marshall technique, or it can be malar flexion, shoulder traction, or you can use Piper's forceps. But if back of the baby is posterior, then there is only one maneuver which is used to deliver the head of the baby, and that is called as Prague's maneuver. Right? So now in this case, because the back is anterior, that is why I am calling it as Byrne-Marshall. Compare Byrne-Marshall. So this is Byrne-Marshall, where the back of the baby will be anterior and you are lifting the feet of the baby towards mother's abdomen. Compare it with this maneuver. Although this is also appearing like Byrne-Marshall because feet of the baby are being taken towards mother's abdomen. But over here, the back of the baby is posterior. That is why you are going to call it as Prague's maneuver. So before you mark an answer as Byrne-Marshall, always and always look at the back of the baby, Right? Now, quickly let us revise the maneuvers which are used in breech delivery. So, maneuver number one maneuver which is used for delivering the buttocks in breech, and that too in case of flexed breech, is groin traction, where you are giving traction in the groin area and the legs of the baby get delivered. This is used when it is a case of flexed breech. What is a flexed breech? When hip joint of the baby is flexed and knee joint of the baby is also flexed. Now, if it is a case of frank breech means that the hip joint is flexed but knee joint is extended. In this case, for delivery of legs, the maneuver which you use is Pinard's maneuver. You will see that in the examiner or the obstetrician is taking her fingers up till the popliteal fossa. Right, so P for Pinard's maneuver, P for popliteal fossa. Whenever you are seeing that the fingers are being taken up till the popliteal fossa and the legs are being delivered, it means it has to be a Pinard's maneuver. Next is, if you see an image where the legs of the baby are delivered but the shoulder is not delivered. So the maneuver which is used for delivery of shoulder is called as Lovset's maneuver. In Lovset's maneuver, you have to hold the back of the baby and rotate the baby. See, we all know that whichever part has to be delivered, it should lie directly behind the pubic symphysis. So when the shoulders are not getting delivered, I'm presuming that the shoulders are not lying directly behind the pubic symphysis. So I am rotating the back of the baby so that shoulders lie directly behind the pubic symphysis. This maneuver is called as Lovset's maneuver. Now, for delivery of after coming head of breech in dorso-anterior breech, if you see that the legs of the baby are being taken towards the mother abdomen, that is Byrne-Marshall technique. Or in dorso-posterior breech, if you are seeing that the legs are being taken towards the mother's abdomen, that is Sprague's maneuver. Now, in a dorso-anterior breech, if you are seeing, so again this is dorso-anterior, the back is anterior. If you are seeing that two fingers are present on the cheek and then fingers are, other hand fingers are present on shoulder. So two fingers present on cheek, other hand's fingers present on shoulder, then that means you are performing malar flexion shoulder traction, or MSV maneuver, Mauricio Smiley Wheat technique, right? Next very important question is that a lady complained of lower abdominal pain. On ultrasound, right adnexal mass was seen, septa was seen. What are the tumor markers you will send in this case? Now over here, the age of the lady which was given was around 18 to 20 years old. So what am I suspecting? I'm suspecting germ cell tumor. Whenever I'm suspecting germ cell tumor, I should get alpha fetoprotein levels done, I should get LDH levels done, and I should get HCG levels done. Right? In case of epithelial ovarian tumors, you have to get CA125 level done. But CA125, epithelial ovarian tumors are seen in females who are around 60 years of age and not in 18 to 20 years of age. So ideally, I should not be choosing tumor marker as CA125, but in your options, every option had CA125. So CA125 has to be included. Other than that, you have to include alpha fetoprotein, HCG and LDH. In other words, your option B is the correct answer. Right? So these are all the tumor markers which are there in ovarian cancer. Very, very important. Next is a primigravida is an ambulance underwent precipitate labor. What do you mean by precipitate labor? Precipitate labor is when the entire duration of pregnancy, when the entire labor is completed within 3 hours, right? When all stages of labor, they get completed within 3 hours, then that is called as precipitate labor. In precipitate labor, everything is happening in such a quick manner that there are high chances of perineal tear. So they are saying the following is noted, identify the type of injury. Now, in this case, they are showing you that the anal sphincter is torn. Right, and they are showing you that the external anal sphincter is torn, and they are also showing you that the rectal mucosa is torn. So please remember, If for grading of perineal tear, grade 1 perineal tear means when the vaginal mucosa is involved. Grade 2 means when the muscles are getting involved. Grade 3 means when anal sphincter is involved. And grade 4 means when anal sphincter and rectal mucosa are involved. In this image, anal sphincter and rectal mucosa are being involved, so it is called as 4th degree perineal tear. Please remember, 3rd degree perineal tear has 3A, B and C. 3A means less than 50% of external anal sphincter involved. 3B means more than 50% of external anal sphincter involved. 3C means internal anal sphincter involved. Grade 3 and grade 4 degree perineal, 3rd degree and 4th degree perineal tear, they are called as complete perineal tears, and they should be repaired in OT under general anesthesia. Whereas 1st degree and 2nd degree perineal tears are equivalent to episiotomy, and that is why they should be repaired in labor room under local anesthesia. Right? Then, important points which you have to remember after repair is you have to give laxatives for 3 to 4 days. A single dose of antibiotics should be given. Pregnancy should ideally be avoided for 1 year after perineal tear, 3rd degree and 4th degree perineal tear, and minimum for at least 6 months. In future, they can undergo vaginal delivery, but if there has been history of twice perineal tear, if there has been perineal tear twice, then 3rd time you will have to go for cesarean section. Next question, after ovulation, egg is in which phase? First of all, understand what do we call as egg. Egg is the secondary oocyte, right? So you all know that at the time of oogenesis, right, we have the oogonia. Oogonia is 46XX. Oogonia is going to undergo mitosis and it forms primary oocyte. This is happening in intrauterine life. Then this primary oocyte is going to go into meiosis 1, but meiosis 1 gets arrested. In which stage? It gets arrested in diplotin stage of prophase. And nothing further is going to happen in intrauterine life. At puberty, this primary oocyte will get converted into secondary oocyte and first polar body will be released. The chromosome number of each one of them will be 23X. Now, this release of secondary oocyte from primary oocyte is called as ovulation. And when we say every month an egg is being released, egg is nothing but it is a secondary oocyte. Now, this secondary oocyte starts undergoing meiosis 2, but again meiosis 2 is arrested in metaphase. And this arrest is going to be over only at the time of fertilization. And at the time of fertilization, the secondary oocyte is going to change into a female pronucleus and a second polar body would be released. Chromosome number will remain the same because after meiosis 2, chromosome number remains the same. So now the question which they have asked you is that egg is in which phase? So egg is a secondary oocyte with meiosis 2 arrested. That's the right answer. Next important question, Nugent's score of a woman's sample was found to be abnormal. What is the likely diagnosis? So Nugent score is a score which is done in gram staining for bacterial vaginosis. And if score is more than equal to 7, that indicates bacterial vaginosis. Please remember there are certain terms which you have to remember for each of these vaginitis. For example, trichomonas vaginitis, they are going to say that there is greenish yellow frothy discharge. Words like strawberry vagina and motility present, all of them indicate that they are talking about trichomonas vaginitis. In candidiasis, they are going to say that there was a curdy white discharge, intense pruritus. Patient's problem is not discharge in candidiasis. In candidiasis, the patient's problem is intense pruritus and splash dysuria can be seen. In candidiasis, the pH of the discharge is less than 4.5. Then comes bacterial vaginosis. In bacterial vaginosis, there is no pruritus. You get a grayish white discharge, but the discharge has foul smell, and that is how you differentiate bacterial vaginosis from leukorrhea. Leukorrhea is also colorless, and bacterial vaginosis can also be colorless. Leukorrhea also does not lead to any pruritus. Bacterial vaginitis also does not lead to any pruritus. But leukorrhea never has foul smell. Bacterial vaginosis will always have foul smell. Now, in bacterial vaginosis, they will also use terms like clue cells. What are clue cells? Clue cells are vaginal epithelial cells to which the bacteria are adhered. Right? Then they can use terms like Nugent score. Nugent score is done on gram staining. Then they can use terms like whiff test. What is whiff test? When you add 10% potassium hydroxide to the discharge of bacterial vaginosis, you will get an amine-like odor. And if they use terms like Amsel's criteria, again, Amsel's criteria is a criteria which is associated with bacterial vaginosis. Amsel's criteria says that out of the following four, any three should be present. And what are they? Number one, you should be getting a grayish white discharge, which should be thinly coating the vagina. A grayish white discharge, thinly coating vagina. Number one. Number two, pH of the discharge should be more than equal to 4.5. Number three, clue cells should be more than equal to 20%. And number four, whiff test should be positive. Out of these four, any three should be present, and then we say that there is bacterial vaginosis. Next question. An unmarried girl presented with amenorrhea and abdominal pain. On her genital examination, she was found to have softening of the cervix. What sign is this called? Softening of the cervix means we are talking about Goodell's sign. And Goodell's sign is the first sign to become positive at 6 weeks. There is another sign which is called as Hagar's sign. And Hagar's sign is because of the softening of uterine isthmus. It is not because of the softening of the cervix, right? Then, and this is how Hagar's sign is elicited. Next question. A 24-year-old woman was brought to hospital at 34 weeks of gestation and admitted for preeclampsia with severe features. You have administered magnesium sulfate. Which of the following is not a part of monitoring? Urine output more than 30 ml per hour. You are going to do that. Respiratory rate more than 14. Ideally, it's more than 12. Deep tendon reflexes should be present. Routine measurement of serum magnesium levels. No, we don't do routine measurement of serum magnesium levels. Next question. A 28-year-old woman, G4P3L3, one normal vaginal delivery and previous 2 LSCS comes to you at term. She has active genital herpes infection. What is the preferred mode of delivery? Please remember, active genital herpes is in itself an indication for cesarean section. Number 2, this patient has history of previous 2 LSCS. According to our national guidelines, if there is previous to LSCS, then next time you have to do LSCS. Genital herpes is not an indication for classical cesarean section, right? So I'm going to go for elective cesarean section. Classical cesarean section ka indication hota hai if there is cancer cervix or if it is a perimortem cesarean section, or if the bladder is adhered onto the lower uterine segment, or if lower uterine segment is not formed, or if there is a placenta previa with blood vessels lying all over the lower uterine segment. So they are indications for your classical cesarean section. Next question. A 30-year-old G2P1L1A1, she was conceived with IUCD in situ. Thread is clearly visible. What is the next plan of action? Such an easy question they have given. So now pregnancy has happened with IUCD in situ. If patient wishes to continue her pregnancy and if thread is visible, you have to remove the IUCD, right? If thread is not visible, then you have to continue the pregnancy with IUCD. Please remember, IUCD is not teratogenic, but it is associated with increased chances of infection, increased chances of abortion, PROM and preterm labor. Now, if patient does not wish to continue pregnancy, then you have to remove the IUCD and you have to go for MTP. So over here it is that I have to gently remove the IUCD, right? Next question. A 55-year-old obese woman comes with postmenopausal bleeding. She has diabetes and she has hypertension. Endometrial sampling was done. Histopathological examination is seen and tissue comes out positive for P10 gene. Now, so many hints which they have given over here. Whenever you have an obese female who is diabetic plus she has hypertension, there are this is what is called as corpus cancer syndrome, because these females have increased chances of endometrial cancer, number one. Number two, endometrial cancer in which you are getting obesity as a risk factor means that this is estrogen dependent endometrial cancer. Number two, P10 gene is positive. Now, if P10 gene is positive and it is estrogen dependent endometrial cancer, that means it is type 1 endometrial cancer. Type 1 endometrial cancer includes adenocarcinoma, which is also called as endometrioid tumor. Please remember, type 2 endometrial cancer is not associated with excessive estrogen. Type 2 endometrial cancers are seen in thin females, and type 2 endometrial cancers are associated with mutation in KRAS gene and P53 gene. Remember that in case of your type 2 endometrial cancer, the varieties which come mostly under type 2 are papillary serous variety and clear cell carcinoma. So over here what you are getting is endometrioid cancer. In endometrioid cancer, on histopathological examination, you will see very less stroma and it will seem as if the entire slide is full up of only glands, and this is what is called as back-to-back arrangement of glands. Clear to all of you? Yes? Okay. Next important question. A 28-year-old P2L2 comes with complaints of mass descending per vagina. She wants to retain her fertility. You are doing abdominal sink surgery and mesh placement is done. What is the site? Please remember, whenever you have to place a mesh, whether you are placing a mesh for vault prolapse or whether you are placing a mesh as a part of sling surgery, you have to place it on sacral promontory. Mesh has to be placed on sacral promontory. When we are talking about slings, again, in sling surgery, the most commonly performed sling surgery is which one? Shirodkar sling surgery. And in Shirodkar sling surgery, posteriorly you are attaching the sling to the ligaments which are present on sacral promontory, and anteriorly you are taking it up till the isthmus of the uterus, right? Then the one which is not that commonly performed is Purandare sling surgery. Purandare sling surgery. In Purandare sling surgery, you are placing the sling on one side, you are attaching it to the isthmus of the uterus, and on the other side to the rectus abdominis sheath, right? So that is Purandare sling surgery. But whenever you are placing a mesh, whether you are placing it for vault prolapse or whether you are placing it as a part of sling surgery, mesh may one side has to be attached to sacral promontory. Now depends, if you are doing it for vault prolapse, then one side sacral promontory, other side you are going to take it to the vault. What is vault? That is the vaginal stump which is left after hysterectomy. And if you are doing it for as a part of sling surgery, if you are putting a mesh, then on one side sacral promontory and on other side to the isthmus of the uterus. This over here, what I have written is isthmus of the uterus. Clear to all of you? Next question. A 42-year-old woman, P2L2, who had a last pregnancy 20 years back, comes with complaint of heavy bleeding and a smooth pinkish round globular structure is seen. On bimanual examination, uterus is multiparous firm and cervix admits one finger. What is the most likely diagnosis? Now you tell me, a patient who had delivery 20 years back, can I get a placental polyp? No. Can I get uterine inversion? Chronic uterine inversion can be seen. But in a case of chronic uterine inversion, the entire uterus is hanging out like this. Right? There is no place to put that one finger. Right? You can't admit one finger inside the cervix. Right? Hypertrophied cervix. In case of hypertrophied cervix, you are not going to get something like this where a pinkish round globular structure is seen coming out. Right? So it is not a hypertrophied cervix. And again, if it is a hypertrophied cervix, the mouth of the cervix will be closed. The cervix will be stenosed. Right? You cannot admit one finger. So this over here is a myomatous polyp. Next question, a 21-year-old woman at 10 weeks of gestation comes to you for MTP. Which method would you like to perform? Now, this is again a controversial question. See, in first trimester method, we have mifepristone and misoprost, but they can be used only up till 9 weeks. Right? When it comes to dinoproston, we don't use dinoproston generally for doing abortions, and even if it is used, it has to be used, right? It has to be used in second trimester. So dinoproston, if you are going to use it in second trimester. Intrauterine installation of hyperosmotic saline, again, it is a method for MTP in second trimester. Oxytocin is a method for MTP in second trimester. So the only option which is left with me is mifepristone and misoprost, and that is why we will mark that as the answer. Ideally, at 10 weeks, what you should be doing? You should have done suction evacuation. Suction evacuation can be done up till 16 weeks, but it is the best method to do MTP between 9 to 12 weeks. So, suction evacuation, right? It is the best method. It can be done up till 16 weeks. So, this is how the first trimester method and the second trimester method. In first trimester, we have medical abortion, which is an OPD procedure using mifepristone and misoprost. Then you can go for suction evacuation, manual vacuum aspiration, and menstrual regulation. Menstrual regulation is outdated these days. Second trimester mein you can go for prostaglandins like misoprost, carboprost, and you may use dinoproston, oxytocin, extra-amniotic ethacridine, intra-amniotic saline. Then suction evacuation, because it can be done up till 16 weeks, dilatation and evacuation, and hysterotomy, right? So this brings us to the end of the discussion of this paper. Please remember that NEET-PG questions may not be repeated in your INI-CT or in your FMG, but the topics are extremely important, right? So all these topics on which questions have come are extremely important, whether you are an INI-CET student, you are preparing for INI-CET, whether you are preparing for NEET-PG, or whether you are preparing for your FMG exam. So I'm going to end it with this, one of my personal favorite quotes. You need goals that give you goosebumps, friends that give you energy, lovers that give you butterflies, a mission that makes it impossible to sleep and irresistible to wake up. Just don't concentrate on one line over here, read it in totality, and this is what you should all be having as an aim. Aim that you are going to get a good rank and work for it, and I'm telling you, all of you have that capability of achieving your dreams. Just have that consistency and just keep on moving towards your goal. That is all what is required. All the best to all of you. Lots of love and lots of luck to all of you. Take care.